Dr. H.S. Rathore and Dr. Hamid are presenting, and Dr. Paras can also join. 3 people.
Yes, ma'am.
Dr. Hamid has probably not joined. So, Dr. Brijesh, can you call up Dr. Hamid and request him to join?
Yes, madam.
Okay, he has just joined. He has just joined. Unmute him.
Good evening, Maheshwari. Hello, Vijay.
Yes, sir.
Vijay, yeah.
Yes, yes, sir.
Dr. Gite is joining. Dr. Hiren is joined.
No, sir. I'm again calling.
Just call him and then we'll start.
Yes,
Huh?
yes.
Dr. Hudeda, Dr. Hudeda, you can also ask question today.
Hello.
Right.
Ha,
Dr.
Gaurang.
Hudeda,
Yes, yes,
yeah.
sir. Yes, sir.
Huh?
I'm
Pankaj
there.
bhai,
Yeah, yeah.
yeah. Pankaj
Yeah.
bhai, can we start now? You are there?
Yes, I'm there. We can start.
Oh, fine. Vijay, you can start.
So, 72-year-old male patient with symptoms of LUTS, 1P score has been mentioned. In hypertensive, controlled on medication, has grade 2 prostate on DRE, normal rectal mucosa. Investigations have been given, and USG shows 70 gram of prostate. The pre-void 520 and post-void is 182 ml. So patient went TURP and later presented with following image. Image is in the next slide.
Yeah. So, Dr. Rathore,
Yes, sir.
yeah. So, this is what we got a call from the uh, staff nurse that patient has got bleeding. So, this is the situation.
Yes, sir. So, it's a probably it's a if there was no bleeding after the post-op, immediately post-op, and it's after the 6 hours only, then it's probably the reactionary hematuria, sir. So I want to know the pulse BP of the patient, how the patient is general condition, sir, and so and once is so if the patient is hemodynamically unstable, so I will first is stabilize the patient with IV fluid, or if required blood transfusion, and simultaneously I will also put the if the patient must be on 3-week catheter only. So I start the if irrigation is continuous, I will do the Tumis clot irrigation by the Tumis syringing, or and if it's not stopping or if it's continued, then I will take patient again in OT and do the cystoscopy and do the fulguration.
So, who else is answering? Who else is answering with him?
Dr. Hamid was there, sir. I love it. Good.
Paras. Paras is there.
Yes, sir.
Okay.
Hello.
Yeah, Paras.
எதுக்கு சொல்லணும்னா உங்களோட பைக்
Hello.
நேத்து வந்து தகரத்துக்கு போயிட்டு இருந்தானுங்க. பெட்ரோல் எடுக்க என்னாச்சு, கடைசியில் எடுத்துட்டாங்களா?
Who's background music?
படிக்க தள்ளு போனீங்களா? புரியுதுடா
Who's
உன்னோட
answering?
how much டா?
Please mute yourself. Paras, mute yourself. I think. 1 plus.
டிவைட் பண்ணி சொல்லு. நீயே சொல்லு. அது எனக்கு தெரியாது. Like 5 o'clock till morning. Then up to what time? I'll check. 11:30 I'll call.
1 plus 7. Please mute yourself. Yeah, Paras, you tell me what you are going to do.
Sir, first of all, I would like to know about the vital of the patient, the heart rate, the blood pressure. Has the patient was the traction was applied? I want to see if the traction has been pulled off, or how is the patient general condition? Is he drowsy, or is he well alert? And then I would
No,
like to.
he has already said all these things, and he has said that he will look after once he will settle the patient. Correct? He already the blood cross match, everything is done. If required blood is given. Patient has been stabilized. Now what you will do?
I will give a bladder wash and reapply the traction. And if
Okay,
the
you are given
bleeding
the
is still
bladder was
continuing,
fluid is going inside, nothing is coming out. Now what you want to do?
so then after stabilization, I would take the patient in OT. So there is clot retention. Patient may require cystoscopy and clot evacuation with fulguration of the bleeding source.
So someone has said that this patient has got. Do you think that this patient will have a very high BP after this bleed? And what is the cause of this bleeding? What is the cause of this bleeding?
So it can be because of a sudden increase in the blood pressure, or it can be because of sudden movement of the patient, or hello.
Yeah. Hello.
Yes, sir.
Yeah. What do you think? Why this bleeding has taken place? And what type of bleeding is this?
Sir, this is after the 6 hours. It's called the reactionary hemorrhage, sir. So probably it's because of the displacement of clot, sir. It's because of the high pressure or because of either we increase the intraabdominal pressure because of the cuff or straining. It will lead to the bleed, sir.
So do you think this bleed has occurred because of straining?
He may be pulled out the catheter or
So let me ask you two questions. Somebody said we'll give a bladder wash, we'll apply the traction properly. Suppose you give bladder wash and apply traction and it clears. And then you observe the urination and then it comes clear, but in the intermittently it keeps coming red. Again it becomes clear, again it comes red. What do you think it is? That was the first question. Second, this kind of bleeding, what you're seeing, sir's question was, what do you think it is? What type of bleeding is it?
So pulsatile bleeding is mostly arterial. If the urine is clear in between and it is coming in in a pulsatile manner, then it's mostly arterial. In this picture also we can see a bright red uh, color of, so it is most likely arterial vein. And it can be because of dislodgement of the clot, maybe because of straining or cuff or increase
So
in
do you
blood
think
pressure.
that is going to, is that kind of, no, 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 but is that dislodgement of clot? I don't know, but does this kind of bleeding respond to traction and
No, no,
whatever
no.
wash and all that? I don't think
Only
so.
the venous bleed or venous sinuses bleed are known to respond to traction. Arterial bleed such kind of bleed may require
Yeah, so if a
pulverization.
sinus is opened and you have not applied the traction properly, yeah.
It's look like a arterial bleed only, sir. But if the traction is not there, we can attempt tractions, and then if bleed stops, then it's good. Otherwise, we'll
Who
take him in
who is
OT.
answering? Is it Paras?
Yeah, yes, sir. Yes, Paris and Dr. Rathod, sir. Hello.
Yeah.
Yes, sir.
Okay. So one is that we are saying that just because of increased intra-abdominal pressure, sudden dislodgement of the clot and rise in blood pressure can give rise to sudden bleeding. Correct? That is number one.
Dr. Gaurang, can I ask one
Yeah.
thing?
Yeah, please.
What type of anesthesia was given? Whether it was a hypotensive anesthesia?
No, it means it was
Sometimes
a
to
spinal
reduce the
anesthesia.
bleeding during TURP,
Yeah.
they keep the blood pressure at a lower level. So hypotensive anesthesia they give. Was it
Correct.
whether it was given or not? That is also important thing.
Yeah. So in this case, spinal anesthesia, so by which initially about 20 millimeters, 10 to 20 millimeters blood pressure is decreased initially, but it was not a hypotensive.
Okay.
Yeah. So Rathod, so first you said intra-abdominal pressure and the rise in blood pressure. Second thing is
Because of
the traction which was applied. Okay,
sir,
patient
sir.
might have moved his leg or he is restless, and that may be the cause. Third,
Yes, sir.
Clot dislodgement also.
It may be a patient because of high blood pressure also. The patient may have a post.
this is a very bright and arterial type of very profuse
Yeah,
bleeding. But
sir.
sometimes it also happens that you might not have removed all the clots or chips, and something gets obstructed, your fluid goes inside, patient will have distension, and that also can cause expansion and bleeding. That is
So
another.
can you enumerate, Dr. Athod, can you enumerate some important operative steps to prevent this kind of hemorrhage or to ensure that this doesn't happen to any other patient? Can you enumerate some important steps?
Sir, once you done QRP as a standard process, then you just stop the inflow and see if there is bleeding is coming or not.
No, that was your last point. That is the last thing. But when you are starting the TURP, can you enumerate some important steps?
So you start QRP from the 6 o'clock, and then it go to 5 and 7, then the other lock, and simultaneously you fulgurate every point that is bleeding.
So very good. So first point is that whichever technique you select, whether you do lateral lobes first, median lobe first, Nesbitt's technique or whatever technique you select,
Sure.
the most important thing is to be systematic, right? Rather than running from here to there, go reset some there and go reset some there and then coagulate here and coagulate there. It is better to be a little bit systematic. So first thing is systematic resection. Second, very important point is what you said is if you see a sputter, it is better to tackle it there and then rather than thinking that I will do it in the end. Then, it becomes a big mess. So one is systematic resection. Second is you tackle the bleeding there and then. Third, Dr. Hudavkar sir was saying that you have given hypotensive anesthesia. So some people give hypotensive anesthesia. So at the end, will you do something else?
We'll ask anesthetist to raise the BP to
Very
baseline.
good. So if there was hypotension, whether it was induced or generally because of spinal anesthesia, if there was hypotension, you want to see that the blood pressure is back to normal before you come out. Okay. Last, you will see, check for the bleeding everywhere. You said you will switch off the water, switch on the outflow. All those things you will do. Okay. Then you will ensure that the wash is given nicely. There are no pieces left. Now you have placed the catheter, urine is clear. Now what will you do? What is the important step after placing the catheter?
You inflate the catheter till the 40 cc and put it traction.
That is done now. After that is done.
And then we start continuing irrigation at that moment.
So that is one mistake that people do after putting the catheter and starting the irrigation straight away. Now what happens is when you're about to come out, there is a lot of fluid inside the bladder. So after putting the catheter and after giving the traction, the first step is to empty the bladder completely.
So that is it.
It is only when you empty the bladder and then you use your asepto syringe to give a wash, will you realize that if that one piece or one clot is left inside the bladder, it will only come to the catheter when you empty the bladder completely.
Okay.
So that is a very important step, which many people forget, and they just put the catheter, start the irrigation, and then everything is fine. And at night, suddenly catheter gets blocked. And then all the problems start. So after putting catheter, you should empty it completely. After holding the traction in your hand, empty it completely with your asepto. Then what you give in should come out smoothly. That is a sign that there is no clot or piece left inside.
Yes, sir.
Now, one more thing, important part was when you do the systematic resection, you also understand that at one point you just don't keep on going, that you become deep and then you open a sinus. Then the other lobe is left. So that fine touches you have to give it towards the end. First, you make a good channel and then whatever tissue is left. And one more step in the middle was to keep emptying the bladder. In spite of using continuous irrigation, sometimes what happens is bladder still does not empty well because your inflow is much faster than the outflow. When you empty the bladder, you appreciate what tissue is left, you appreciate what is bleeding, and then you know how to go about.
Okay. Amit, now when you are doing a TURP and suddenly you realize that patient is yawning. So now what you mean by this?
So that is the earliest sign of TUR syndrome. So we just need to see his vitals if he is hypertensive and bradycardia with the yawning. So
okay. So what else then will you ask the anesthetist to do?
I'll ask the anesthetist to
So if the patient is yawning
if it is not, then again two ways. Just placating the fossa or malamine suture, that is air circling the bladder. Close the catheter. This is 1, 2 and 3. Tracking हो गया, malamine suture हो गया, placation of the fossa हो गया. Sorry. हाँ. उसके बावजूद of the intracerebral prostatic, there is free alarm, except attachment at the bladder. Whole prostate is by such technique, it can be removed. So why you are taking the incision initially with the battery? To avoid the distortion of the bladder. What? Then what will happen? There will be in such type of cases, severe bleeding. So what are the options available for stopping the bleeding? First, you have to take the tampon and pack the fossa. Apply the pressure. Wait for some time, 10-15 minutes. Okay. If it is, then remove the pack and react. If it is bleeding, still bleeding, then see under vision any active feeder at 4 and 8 o'clock position because that is the area of the supply at the level of bladder neck to the prostate. If it is thin, contrast with strong constrictive quadri. If it is not thin, then again two ways. Just placating the fossa or malabent suture, that is encircling the bladder neck. For the catheter. This is 1, 2 and 3. ट्रैकिंग हो गया, मेलामेंट सूचर हो गया, प्लाइकेशन ऑफ द फोसा हो गया. सॉरी, हाँ. उसके बावजूद भी अगर लिपिड इज ब्लीडिंग, then you can do scopy from below, just entering the bladder, open bladder, and endoscopically you can cauterize the active feeder. If it is not possible, if it is not available, just pack the fossa and bring that lymph node or the tape walk through the bladder, through the skin, up to the outside, to the anterior wall of the abdomen. And after 48 hours, you have to remove that. If you feel that bladder bleeding is controlled at the level of bladder neck, bleeding inside the prostatic lymph node or the at the level of bladder neck, bleeding inside the prostatic fossa is just for the bleeding. You have to place the previous bolus catheter, inflate the balloon, and give it traction. So where balloon should be kept? Balloon should be kept inside the bladder. If you put inside the prostate, it will what it will cause? Why it put kept inside the bladder? Because the traction you have to give is at the level of the majority of the supply is at the level of that. Because the entry point of the supply, blood supply, is at 4.8 o'clock. If that gets compressed, the fossa inside will think that will come and hematoma will form and that will get automatically stopped.
कौन बोल रहे
Irrigation and how the catheter will remove and when to remove, we will discuss that. Then if you are not confident, place this. I usually place this. Place this SPC and PVC both. Suppose that catheter get blocked. Suppose that accidentally the valve get deflated. At least there is one access to the bladder.
Hello.
So this is all about the post-status.
I think Dr. Gite.
Anybody have question? Particular
No.
Suppose
Gite sir,
bleeding has
आपका कुछ रिकॉर्डिंग कोई लगाता है?
now what we will do?
नहीं, मैं नहीं हूँ सर, मैं नहीं बात कर रहा हूँ.
आप बात नहीं करते हैं ना?
ऐसा लगता है
नहीं.
आपका आवाज जैसा ही लगता है, मेरे को भी ऐसा लग रहा था. I don't know who's
No,
talking.
I think your early recording thing is someone is quoted.
Yeah.
नहीं, मैं अभी नहीं बात किया सर. एक में एक
नहीं,
भी
but
वर्ड नहीं.
Pushkar, are you playing the recording? Pushkar is his.
Yes.
Pushkar Srivastav, were you playing any recording?
No, Pushkar has.
Right now, I have not uttered one word in this.
I am looking
No.
at that, sir. I am also seeing that.
Correct. I think Pushkar.
But definitely the previous class, what all you have said, how to tackle the bleeding, that has been being played by Pushkar Srivastav.
मैं यहाँ तो लाइव जिंदा खड़ा हूँ ना अभी.
वही हम लोग वही सोच रहे हैं. मैं
रिकॉर्डिंग
भी
क्यों
सोच
बजा
रहा
रहा है?
हूँ. मैं ही सोच रहा हूँ कि सर का आवाज है, सर का एग्जैक्ट कॉपी कौन कर रहा
Pushkar was
है?
playing that.
Yeah, Pushkar
Anyway.
was playing it.
Correct.
नहीं सर.
Pushkar was playing it. So sir, Venkat sir, you only please ask the question. And,
If discussion is going about the post-TURP bleeding, so whatever that is for the open surgery. Whatever
Correct.
that discussed in last 10 minutes, 2 to 3 minutes by playing the recording,
So there are different techniques for different technique of controlling the bleeding for different treatment. जैसे आप ओपन सर्जरी कर रहे हो तो उसका अलग टेक्निक है, एंडोस्कोपी का अलग टेक्निक है, ब्लीडिंग अर्ली आइडेंटिफिकेशन, ये सब चीजें.
So you can ask about this is a post-TURP, the patient is now bleeding. So now we have to continue from here. So you please
सर
ask
सुनने
them
को नहीं
question
आया
and
आपका.
so let us continue from here.
Yes.
Yeah. Okay. So Mohammed, Amit,
Yes, sir.
now you have taken the patient. Now another thing is that I was asking about the when the capsule is open, patient is yawning. So the blood pressure also will be high. And how will you find out when there is a capsule is open? What are the features you will see?
Sir,
One is yawning, second
vitally
is rise in blood pressure. Now
blood
third thing,
hypertension, bradycardia will be there,
okay,
and
okay,
the saturation of the patient will fall, and
okay.
clinically these
So that is clinical you're saying. Now endoscopically what you see?
endoscopically we can see if there is a breach in the capsule, and
Okay,
or the
that is
sinuses
number one.
or sinuses are open.
Hmm.
So if we are like at the end of the procedure, we can proceed with the we can do the procedure, complete the procedure, and if we are at the in midway of the procedure or the starting of the procedure, we can.
So which are the other, I am asking you, which are the other different ways to find out that this is a sinus bleeding or sinus stenosis? So one, you
Sorry,
said
sir.
that you can
You're
see the breach in the capsule. Number one.
Yes,
Number
sir.
two. Number two.
It's a continuous non-pulsatile bleeding will be there.
So the bleeding,
So
when you go
arterial.
away from the bleeding, when you go away from the bleeding, it will show that there is a bleeding, and when you go near to that, the bleeding will
Stop.
stop. Okay, because your infusion pressure is more than the venous. Correct. First thing will
Yes.
be when you give the wash, there will be a vast difference between the arterial bleed and venous bleed.
Venous bleed. Yes, sir.
Okay. So now Dr. Gite has asked you, now you are coming across such a bleeder. Whether it is arterial bleed, so you like to stop it.
Sir, you're not audible clearly to me.
Okay. Can you hear me now?
Yes, sir.
No. So the question is that now there is a bleeding. How you are going to stop it? It is an arterial
Sir,
bleed and it is a venous bleed.
if it is an arterial bleed, we can advance the scope inside the bladder and gradually take the scope back. And whenever we can appreciate the arterial bleed, we will do the point coagulation of the arterial bleed. As the arterial bleed stopping is, they are like more prone to stopping because of the thick arterial wall, and they will go into the spasm. But if the venous bleed is there, and we can try to attempt the coagulation. If it is not possible, then we can
Mohammed,
stop it
now
by.
all you guys are exam going. Don't keep on saying we. You
Sorry.
say I will take the
Yeah.
patient to the OT.
Yes.
I will
Yes, sir.
explain the relatives. Maybe there is a arterial sputter, and
Yes.
plus I need to evacuate the bladder, give good wash, identify where it is bleeding from, and tackle that bleeding. I will talk to the relatives. I will keep blood reserved. I will talk to the anesthesia, and then I will take the patient to the OT. Don't
Okay,
say
sir.
we can do this, we can do that. We know what we can do.
Okay.
Some
Okay.
examiner may answer like that to you. Then you will
Okay,
get
sir.
nervous. Okay, so you have to say that I will do this.
Okay, sir.
Haji.
So I'll take the patient. I'll explain the relatives about the most probable cause of the bleeding. If it is continuous, then it is probably arterial bleed. If it is intermediate, that it's probably the venous bleeding. We can give the bladder wash. If it is not stopping, then we can take the patient to the OT and do the point coagulation if it is arterial bleeding, and if it is, and also address the venous bleeding.
Okay. So now the blood pressure is 220 by 120 and the bladder is full. So during the TURP, if there is a venous bleeding, then you will not continue. If it is a, capsule has been opened and you would like to
Yes, sir.
abandon the procedure
Abandon the procedure. Yes, sir.
and you will give the, put the Foley's catheter three-way. Okay.
Sure.
Yes,
Give the traction, give the thorough wash and see that the returning fluid is clear and then start the irrigation and give the proper traction. Fine.
yes, sir.
Now in this patient, now you have taken the patient inside. Patient's BP is 220 by 120 and the bladder is absolutely full. How you are going to plan? Before surgery only you will decide that these are my steps. I will like to do this. Or you will just go
No, sir. When
and
there is active bleeding, when there is
shoot
an active
in the...
bleeding, when there is an active
No,
bleeding, when
you don't
like
know. See, I'm telling you, this is patient has got a retention, clot retention, or urine is also there. His BP is very high, 220 by 120 now, and you are
sir,
taking him in OT.
so if the patient is in ward or then I will
He is in a ward. This
yeah.
patient is in the
So
ward.
I will try to take the lower down the BP first of the patient and observe him. If the bleeding continues, then only I will take him to the OT.
Patient's
Arey
bladder
Baba,
is
sir is
absolutely
saying, sir
full.
is giving you a scenario. Bladder is full. Patient is crying now. Bladder is full. Clots are filled inside. Urine is also filled inside. The patient's BP is high. Relatives are saying, doctor, do something. You'll give some
So
hypertensive when it will act.
yeah, then I will take immediately patient to the OT
So you
and
need to
do the
explain
clot
the
evacuation.
relatives. Again, you need
Yes,
to see that he stabilized, little calm down. You need to see that the blood is arranged. You need to talk to the relatives that there is a hypertensive crisis right now. Plus, he's also in pain and bladder is full. That could also be contributing to that hypertension, anxiety, and everything.
yes, sir.
You will
Yes,
also need to discuss with your anesthetist that how do we bring this down in control. You don't want
yes,
hypertensive anesthesia again because what if you miss the bleeder? You just want it
yes,
to be normal pressure. At
yes,
least bring it down a little bit so that you can observe where it is bleeding from.
yes,
Okay, these are all practical points you need to think. You cannot just take the patient to OT. You have to talk to relatives, explain them that this bleeding has happened. We don't know why it has happened. Maybe it is because of hypertension. Sometimes patients are on blood thinners and they have not told you. So many factors come
yes,
into play.
yes.
Okay, so now you have taken patient inside. Which anesthesia you would like to give?
Sir, I would preferably take the patient under the general anesthesia
General anesthesia
with the muscle deep muscle relaxation. Sorry.
Okay, and what you will do?
I'll put the resectoscope sheath and remove the clots with the aseptic syringe or the Toomey syringe and then find out any active bleeding is going on. If the active bleeding is going on, then I will tackle it at that time only. If the yeah, if at that time only, and once the clots are removed and the bleeding is
So
settled,
you
I'll
go inside and it is absolutely red, and lots of clots are there. You have removed the clots and still it is bleeding. You are not able to stop the bleeding.
I I'll ask the anesthetist to lower down the blood pressure a bit, and then if I can find
Very
the
good.
bleeding point, then
Anesthetist has lowered the blood pressure. Now bleeding has come under control. You put the catheter. Again, patient has gone to the ward. Again, BP has become 140 by 100. Again, it has started bleeding.
Pankaj bhai,
Sir,
can you just
sir, like this, I have seen one patient in which we have like gone for 3 or 4 times in like endoscopically, but we couldn't find the bleeder at that time. So eventually, we decided that if the bleeding point is not visible under direct vision on multiple attempts, then we should consider patient for prostatic artery embolization.
so
That
step by
patient which you
step?
took 4 times, your teacher was there, sir was there with you, or you were only doing alone PGs?
No, sir was there, sir.
Okay.
So you see
So
Okay.
that is
sequence,
that
the
is an
sequence,
extreme case. Yeah.
Yep.
Yeah.
Pankaj
Sir
bhai,
is going to
please.
tell the sequence. Yes.
the
Yeah.
sequence of event would be we would go in with a endoscope, try to get rid of all the clots. It is important to separate the clots which are stuck to the wall. Many times the bleeders are behind these clots. So with a loop, separate the clots, try to see the bleeders behind these clots. Then at the end of procedure, once you are happy that you have done coagulation, you may use loop, you may use a ball electrode. Once this is done, if the urine is clear, then you put in a catheter, inflate the balloon to around 30 to 50 cc, give traction so that the balloon is at the bladder neck and doesn't slip back into the prostatic fossa, start irrigation, wait. In a patient who has recurrent bleeding, before going for prostate artery embolization, one more thing which could be done is probably a open packing of the prostatic fossa. So the options are endoscopic coagulation, open packing. If that doesn't work, prostate artery embolization. If that doesn't work, internal iliac artery ligation. So this would be the sequence of events.
Yeah.
Okay.
And this is what is expected in exam. You
Okay.
understand? So always say, sir, I'll stabilize the patient. Patient is in agony and anesthesia. What anesthesia will give? That you have to say why you are going to give that anesthesia. Then go inside, give proper wash. Suppose if you are not able to do anything, you should be prepared, as Dr. Maheshwari said, even before coagulation also, you might have to open up. Because when you go inside, there are so many clots, you are not able to, BP is going down, anesthetist is saying there is too much of bleeding, please go do something. So in that case, what you will do? Immediately open and remove all the clots and pack it. Because what is
Yes, sir.
more important is the patient's life. Correct? So
Yes, sir.
before doing anything, you must plan out how you are going to work on this patient. Okay. So
Yes,
now
sir.
your coagulation, as Dr. Maheshwari said, that you try to coagulate, it is not coagulating. One of the case it had happened to us that patient had undergone laser. This thing, I think it was not the HOLEP or THULEP, but it was burned, like, green light laser or something. And then still it was after 5 years, it was a very large prostate. That is what everything was saying. And then we did it and it was not contracting and we were not able to control bleeding. Okay. So in that case, we opened up the patient and we packed it. Okay. So now how we are going to pack it? Mohammed, Amit.
Vesically, sir.
Okay. So you are going to open the bladder and
In front
what you are going to
I will
put?
take in.
Have you seen Freya's prostatectomy? Have you seen?
No, sir, I haven't seen, sir.
So that's why when sir asked how you will pack, so you take the roller gauze. Okay, you take 2 roller gauze tied to each other.
any other way of packing except transvesical? ऐसा कोई है क्या?
No, sir.
Obstacle ही पैक करना है.
I haven't seen
दूसरा कोई
the.
रास्ता ही नहीं है ना.
Yes, sir.
How else will you pack, no? So that's why sir is asking practical question. So once in a while, if you have not seen prostatectomy, Freya's prostatectomy, at least watch a video on YouTube or something, and at least have some knowledge on how it is done and how the packing is done.
Yes, sir.
Okay. So now you have packed it and you are going to bring out one end outside from the bladder, correct?
Yes, sir.
Now, how many days you will wait? So how many catheters you are going to put?
Sir, only since we have packed the patient, sir, I haven't seen this, and so I have no idea about this, sir.
Okay, so normally what I do is, after packing, first of all, for urethral catheter, I keep it, bring out the balloon, and around the catheter, I pack the fossa, and then I pull the balloon. So the traction is also given along with this packing. Then another end of the pack is brought out from the suprapubic, and normally I like to keep even per suprapubic catheter also if needed. If everything is clear, everything is fine, and I feel that per urethral three-way Foley's catheter will suffice the need, then I don't do it. But otherwise, normally I put even a suprapubic. It is always better to have a two channel, because if one gets blocked, you have got other to drain the urine. Okay. So now after
And
48 hours,
sometimes they bring the suprapubic out from the separate, so that
yeah,
cystotomy incision and then separately suprapubic,
correct.
so that it doesn't,
Yeah.
the urine doesn't leak.
So wait for 48
Yes.
hours, let everything settle down. And if for 48 hours there is no bleeding, then slowly and slowly you can remove the pack. So after 48 hours or 72 hours, you can slowly remove the pack. And after that, again, pull the balloon little towards the bladder neck and give the mild traction. Normally, better to keep patient not to move and keep the blood pressure, everything under control. Okay?
Okay.
So these
Yes,
are
sir.
the things. महेश्वरी जी आपको कुछ गीता सर आपको ऐड करना है?
नहीं, whenever you are going for open exploration of open clot evacuation, then after evacuating the clot, you have to use all resorts what just recently explained in that video, the video 10 minutes before before going for packing, because packing is a last resort. So
You can
when the fossa or bleeding is in front of you, you just use long tip cautery, try to coagulate, if malament suture, then plication, whatever procedure explained in the book. You use everything, and if, in spite of that, if you are not getting the control, then finally what you have explained is the final resort that
Yeah.
that can be done. So I have experience of one patient which is referred from Kolkata to my boss in 2008. 3 year post-TURP continuous intermittent bleeding, and होता था, सीटी स्कैन किया कि थोड़ा इधर उधर से कुछ, फिर 5-7 दिन में कंट्रोल हो जाता था, एक आधा ब्लड दे दिया कि वो नॉर्मल हो जाता था, ऐसा कुछ भी नहीं मिल रहा था. देन सुपर सेलेक्टिव एंजियोएम्बुलेशन डन बाय वेंकटेश बोल के एक इंटरनेशनल रेडियोलॉजिस्ट हैदराबाद में, ही इज वेरी वेल नोन. तो उन्होंने प्रॉपरली उसको ब्लॉक किया एंड ही इज गेट rid of the bleeding. तो वो केस हमने 2008 में ईस्ट जोन में प्रेजेंट किया. तो ऐसा एक एक्सपीरियंस है. तो बाकी ऐसा तो कुछ ज्यादा सुपर सेलेक्टिव एम्बुलेंस तक जाने की जरूरत पड़ती नहीं है.
नहीं है. Yeah.
And you are allowed
Okay.
to listen to the lectures, but not during the class. Cheating is not allowed.
नहीं, मैं भी सरप्राइज हो गया, मुझे लगा मेरे जैसा आवाज
अरे
तो आ रहा
मैं
है,
सोच रहा हूँ
तो
सर
बात नहीं
देख
कर रहा
रहे
हूँ,
हैं
क्या हो
मेरे
रहा है.
को, मैं देख रहा हूँ सर को. बोल कौन रहा है?
Even I asked Gita sir who is talking.
नहीं, सर ने पूछा मुझे मैसेज करके, मतलब मैं तो नहीं बात कर रहा.
पुष्कर ने हिला दिया सबको.
Pankaj sir,
Correct.
I just want to ask one thing, that
Yes.
should the super selective embolization done after the packing or before the packing? Like because that is less invasive as compared to packing, sir. So I just like want to ask you.
You see, when you are faced with the best result for that patient, it is very difficult to find a bleeder in super selective embolization, and there are not many people who are experienced in doing a prostatic artery embolization. So if you are trapped in such a situation, attempt endoscopic. If it works good, if it doesn't work, then probably I would go for packing before I go for abdominalization.
Like sir said, it may not be available everywhere, so it depends on where you are doing the work also. It also depends on that.
So,
Absolutely.
so in exam, say I will like to go inside. I will like to find out a bleeder. Means I will evacuate everything. I will see that bladder is empty. All the clots are removed. I will like to observe the fossa, find out the bleeder, stop the bleeding. Okay.
Yes, sir.
And in spite of that, that is not happening. You will open up, as Dr. Gite said. You will under vision. You will try to cauterize again, or you will take a stick on 3 o'clock, 5 o'clock, 7 o'clock, or you may take all around the thing, bladder neck and purse string type and put the catheter. If that is not working, then the packing, that is also not working, then selective angio embolization.
Oh,
Okay, that is the
okay,
sequence you must
okay,
do.
sir.
Fine. Okay. Bridges, next case.
So 78-year-old male patient with no any comorbidities, but he's an opium addict and a tobacco chewer since 2 years. Underwent right inguinal hernioplasty. Patient had a complaint of hematuria with passage of amorphous clots since 1 month. Had overflow incontinence with no other LUTs. And prostatic examination had a grade 3 prostatic enlargement, no nodularity, rectal mucosa was free. CT IVP previously patient had done from outside, had bilateral hydronephros, hydroureter, and urinary bladder showed 54 cross 26 mm lateral mass, for which patient underwent TURBT with bilateral PCN. And after 1 week of that PCN, patient presented with severe right flank pain and right-sided abdominal pain and fullness. So image is
Yeah.
here.
Okay, so this patient presented with the fullness in the right side with a severe pain. Okay, there was no fever. And first we thought it is because of the opium. So in spite of giving him opium, he did not improve. So fine. Hamid Rathod, now what you will do?
So I want to know, is the right PCN is still draining urine or not? Because
Yeah, okay. So the lab was draining about 1.5 liters. Per urethral, nothing was there. And right side, it was draining 30, 40, 30, 40 cc. It was blood stain. I mean, absolutely like, blood only,
I
dark
would have
blood.
also asked, Rathod, I would have also asked whether what was the intraoperative notes, whether the orifice is involved, not involved, why PCN was done, what
sir,
was the course after the PCN.
okay, sir.
All these are important questions in history. No, I know
Yes,
you understood directly that PCN may be blocked or removed or whatever, but we
yes,
must know what is the intraoperative findings,
sir,
why
Yeah, so
PCN was
intraoperative
selected.
findings, yeah, so it was a very small capacity bladder. There was a mass right up to the prostate, okay, and involving both the ureteric orifices. It was very
See, that
difficult.
is
In the
that is
notes,
very
it was written,
important.
yeah,
Yeah.
and so the patient was explained that there is bilateral hydronephrosis and hydroureter, marginally raised creatinine. So they had taken the permission, and so they had done the bilateral PCN.
okay, sir. So if as you sir, as you told, right, PCN is draining around 20 to 30 ml urine with blood only. So and that orifice is all involved, as you told in intro finding. So I want to know the position of PCN, sir. So I want to do and this fullness is what I full is it blood or is a urinoma is there. So I want to do ultrasound. It will show me the region cause of the fullness, and it will show me the PCN position also, sir.
Ultrasound is
Bridges,
showing PCN is inside, but you are not able to, radiologist is not able to confirm whether PCN is in. Now what will you do? I don't know what is the ultrasound finding. I'm just giving you a scenario.
okay. Give him the ultrasonography. Bridges, we have got ultrasonography.
He just concluded some vague investigation, like it didn't show us the proper tract of the right PCN, but we have the images of the CT scan.
But that was the next question. So ultrasonography is not confirmatory, so you can do CT, or you can gently do a nephrostogram.
Nephrostogram.
So see everything.
So,
We have done.
Sir, please, sir.
We have done a contrast enhance. Full.
Sir. Sir, after examining the given film, it is observed that right PCN is not in I think position, sir. So left PCN in position with the there is heterogeneous collection at right perinephric space. That is
it is extending up to what level?
It is extending till the L5.
Iliac crest, up to iliac crest.
All up to iliac crest. Can you see all that collection is there all along this first muscle?
And the left drain is
sir.
properly
Yes,
inside.
there-
Where is the right
there
drain?
is.
Where is the right nephrostomy?
Nephrostomy is outside the is in pay.
Just lateral to the PUJ,
PUJ,
seen
sir.
in one film.
Yeah. And what else you see in the bladder?
So bladder shows the thickened wall bladder with the hyperechoic.
There is a the thing, police catheter inside.
Okay, sir. Sir. Police.
Okay.
Yes, sir.
The police catheter. Fine.
Yes, sir.
Okay. Now what, Hamid? What you want to do?
Sir,
So now what is your diagnosis in this case?
so sir, as the PCN is not in the place on the
No,
right
what is the
side,
diagnosis in this
Diagnosis.
case?
Sir is asking diagnosis.
probably collected
Known
hematoma
case
urinary.
of bladder tumor. Known case of bladder tumor. Status post TURBT with bilateral
Involving
PCNs done
both the
outside.
urethric orifice.
With bilateral PCN done outside. Now patient is presented with left PCN in situ. Right PCN is outside the pelvic ileal system. That
And
is
there
how
is a
you should tell.
urinoma. Correct? And there is a urinoma on the right hand side. Correct?
Yes, sir.
Because you can see the contrast coming out on the right hand side.
Yes, sir. Contrast coming out.
Okay. So now what are the
Dr.
options?
Ganesh Bakshi has joined.
Yes, sir.
Welcome.
Ganesh bhai.
Yes, sir. I joined.
Yes. So this is the case where TURBT was done for the biopsy basically, and because of bilateral hydronephrosis, hydroureter, and patient had oliguria and the creatinine was little higher side, so they did bilateral PCN. Patient came to us with the right-sided pain and little fullness, and it was right was not draining anything. So now I am asking them the next question. Okay, what
Yes,
are the
sir.
options
Yeah.
you have got?
Uh,
So Rathod, I will tell you one thing.
Sir.
I will do PCN, number 1. Number 2, I will do the open and I will remove the urinoma also with the PCN. Number 3, I will try to put a double J stent. Number 4, I will put the double J stent if possible, put a nephrostomy and put a drain in the perinephric space. What you want to do?
Sir, I will do. I will try to place ultrasound guided PCN and perinephric
तो
few
बोलना
days.
confidently बोलो थोड़ा please.
Yeah.
Your exam is going to get announced any day, probably by Saturday.
So,
Just
sir,
get
good. Go
attitude to
ahead.
the exam which says that you answer and you should know how to defend your answer.
okay, sir. So, sir, in this case, I will do ultrasound guided PCN with perinephric drain placement, and if I succeed, then I will observe the patient with ultrasound serial ultrasound to see any decrease in the periurinoma or not, sir.
So in this case, isn't the drain outside only, outside the kidney only? No? You can just advance it a bit. It will come into perinephric space.
Okay.
ठीक है,
So
बराबर है.
yeah. So Hamid, what is the next?
Yes,
What you want to do?
sir.
Now this patient, I'll give you the scenario. What is exactly it was? Patient's pulse was okay, BP was fine. I mean, he was absolutely stable. Walking, there was no fever, nothing, but only pain and mild fullness on the right hand side. Nothing more than that.
Sir, before
Creatinine was also normal.
when PCN were placed, sir, what is the output of both the kidneys, sir? And at
See,
that time,
in the notes it was written. In the notes it was written that first day there was a blood in both the nephrostomy. Okay, and then it cleared out. Left side was draining very well. Right side drained for 2 days, about 200 to 300 cc.
How is this
And after
question
that,
relevant? Tell me, how is this question relevant? You have seen the CT
sir,
scan, both the
parenchyma
kidneys.
looks good.
Then why you are asking this question? Do you think that right kidney is non-functioning?
No, sir. I just
It is
want to know.
a good parenchyma, no? Now this has come, scenario has come, drain has slipped out, or probably they placed it in the wrong place. So how
so
does
I'm
it
telling
matter?
you, it was draining for 2 days, 200 to 300 cc, and then
It
it
may
has
have
stopped.
slipped out.
Yeah.
But kidneys are good. Both the kidneys are good. So now you have to salvage it, right?
So since this patient came with a complaint of abdominal pain, although he is not septic or he doesn't have fever, but on CT scan it is clearly seen that the PCN is out of the kidney. So I will reposition the PCN in the kidney, as well as put a percutaneous drain in the collection. This patient
So
mainly
I would have said I'll put a new drain directly into the kidney and just pull this drain more into the collection. This drain is already outside.
okay.
See, the urinoma is not so big. The
Yeah, it will get
ultrasonography people
resolved
told
also.
me, they told me that it is difficult to put a drain because it is like
That is what
not a
I'm trying to
big collection.
emphasize
Yeah.
that only, that the drain is outside. It is already outside the kidney and it is in line with that urinoma. If you just advance, you pull it out a bit, it should take care. And I would place a fresh PCN into the kidney. No? Why try to place this PCN in? How can you do that?
Okay.
Yes.
So I will tell you what we had planned. Okay, Hamid, you have got anything to say?
And
No,
sir
sir.
also said you must think about degestenting. Maybe they have not
Sir,
managed,
as
but
the patient underwent TURBT and it was involving both the sides of the
but
ureter.
Babu, you have not done the TURBT, na? It is done outside. Now patient has come to you.
But we can attempt
While attempting the PCN, you could want to look at the bladder once, whether TURBT was done properly, whether you can see the orifice. If you manage to put in stents, this situation will be solved.
we can try the
And then you will,
ventricular stenting also at the time of placing the PCN.
correct. I would also agree to that. If we are doing, we'll try to do antegrade stenting.
Okay.
So let us listen now what sir has done.
It is better
So
to
what? Yeah.
sir,
Yes, sir. Yeah, bolo.
PCN plus PCD, either new or old advancement, जो भी आपको जैसे तरीके से पुटअप करना है कर सकते हैं. नया डायरेक्टली पीसीएन एंड उसको पुल अप करके पीसीडी, या फिर इसको एडवांस करके पीसीएन एंड नया पीसीडी. That is only answer in this patient,
Correct.
which will resolve all queries of examiner also. अभी रह गया सवाल डिजीज टेंटिंग का. We don't know that what is the grade of malignancy, what is the stage of malignancy, what is the ureteric opening, it is involved, cicatrized, post resection. So first preference will be given to the either of the thing, either pulling up the PCD what in the collection and new patient, or advancement of the PCD in the patient and another PCD.
Correct. And the patient has come to us with pain, sir, and that situation that the PCN is outside.
तो ये बोलने में कुछ डरने का नहीं है. जो ऐसा है तो ऐसा ही करना है, खत्म.
बराबर.
अगर उन्होंने पूछा कि तुम डिजेस्टेंट ट्राई करेंगे क्या,
That's what I said. That sir said that we don't know.
करेंगे, फिर वो उसके ऊपर अगर एग्जामिनर ने खुद होके वो दरवाजा खोल लिया तो फिर वहाँ डिस्कशन बन सकती है.
Because Gaurang Shah sir said, that's why I said कि सोचो कि सर ने भी बोला कि maybe sister digestant goes in. So because sir has opened that option for you, so you should take it and say that maybe I will do a cystoscopy at the same time.
क्योंकि आप डीजे भी डाला तो पीसीडी करना ही है.
Yes.
क्योंकि डीजे will not drain the collection outside the system.
But sir, this patient has bilateral hydronephrosis, and
Why do you think there is
why
hydronephrosis? Why do you think there is
the
hydronephrosis?
tumor probably involving the bilateral ureteric orifice?
So it is muscle invasive, right? Because
Yes,
in
sir.
such a
So
large
shouldn't
tumor
we-
you saw, it was 54 by 26. It is more than a 5 centimeter tumor.
Shouldn't we avoid placing DJ stent in this patient? It
So
will
that's why I'm telling now your first answer is that one. If examiner open the window of digestant, then you can tell that it is difficult, it is already involved on both sides, then high grade malignancy, up migration of the malignant cell, and number of reasons you can give for not placing the digestant.
Absolutely. Because
first
sir asked
answer-
that question, that avenue opened up about digestant.
So now tell us what you are going to do.
So smartly navigate.
I would
So
like to wait
from
for the histopathological examination of the TURBT
Now,
specimen.
what you are going to do in this patient? Just tell us.
So PC, okay. So I will put the ultrasound guided percutaneous nephrostomy in this patient, and like advance the pre-placed drain in the collection, and then observe the patient and wait for the histopathological examination for the further management of the patient.
So what you will do is that under ultrasonography guidance, you will like to place a nephrostomy on the right hand side, right? If the left side is already old, then under CM you can change it at the same time, because we do this procedure in operation theater under CM guidance. Via ultrasonography, you puncture it. Once you puncture, you inject dye, you see the proper calyx that you want to puncture, and then you put a nephrostomy. Correct? So that is the ideal way of doing. At the same time, you tell ultrasonologist to find out whether this drain is properly inside that urinoma or it is not there. And by manipulating, whether you are able to put it in that urinoma or not. If not, then you can put another drain. You can ask the sonologist to put another drain into urinoma if it is draining. Or if it is not too much, he can aspirate also. Fine?
Yes.
So that is, this you must answer as Dr. Gite said, because then you are avoiding all other thing about digestion.
Yes.
Fine?
Yes, sir.
Okay. So what we did, that I will tell you. So we planned out the same thing. We said, okay, we will place the nephrostomy, but I thought that let us do a cystoscopy also, because we have not done, and find out whether what is the status of mass, whether it is involving the bladder neck or not. You know, if we have to plan out any major surgery later on, what we should do. So when we went inside, and I thought that if I get a ureteric orifice, I will inject contrast from below and put a proper nephrostomy. But what happened is that we saw both the ureteric orifices and we were able to put a double J stent on either side. Okay, and then right side under ultrasonography, we saw that there was hardly any fluid. We just manipulated this perinephric drain and came out. Patient has done quite well till now. But in the exam, as Dr. Gite said very rightly, you will put the nephrostomy and you will reposition the perinephric drain, either the same one or put another one. If it is not possible, you will ask ultrasonologist to at least drain whatever is there. Sometimes they say that there is hardly 50 cc, 70 cc. Sir, we cannot put a drain inside. Then tell
It will
him
get
to just
absorbed.
aspirate.
You have to just see that
Yeah.
it doesn't get infected. That's it.
Yeah, but so you just aspirate and send it for culture and other things. Fine.
If you do ureteroscopy or PCNL, large staghorn stone, there will be fluid in the lateral peritoneum.
Maheshwari ji, आपका suggestion?
No, sir, आपने जो कहा सही है. Means I would also probably not have placed a stent. I would have just placed a nephrostomy tube. I would aspirate the fluid. If it looks clear, then probably a perirenal drain is not needed. If it is purulent, then I would put a perirenal drain. This fluid around the kidney does not look very huge in amount.
Yeah.
So probably drain may not be important, but yes, placing the drain or not could be an individual decision. But definitely nephrostomy, and I would not try a stent, sir.
Fine. So all of you now know how to answer in exam. Correct?
So
Okay.
three options for perinephric collection. It is depend upon the size of the collection. You can just conserve it, observe it for spontaneous absorption in the retroperitoneum if it is very small. And if it is moderate, then you can aspirate. If it is very large compressing, then PCD. So these are the, you have to decide as per the, and if it is infected, definitely PCD.
Correct. So now clear? Everyone is clear in their mind?
Yes, sir.
Okay, Hamid, you
Yes,
and
sir.
Rathore are representative. So if you say, both of you say yes, we go ahead. Okay?
Yes.
Yes, sir.
Okay, fine. Brijesh, next case.
A 24-year-old young gentleman underwent injury due to fall from the stairs of approximately 6 feet on a marine ship. He had no head injury, airway was intact, breathing, ventilation was normal, circulation was normal. USG EFAS showed left splenorenal collection with perinephric collection. X-ray, chest and
Let them ask now. What is so now this is a situation. So Rathore, what you want to do?
Sir, I want to do the ultrasound fast. Yeah, okay, so already written.
Okay.
Nephric, chest 15, permanent tenderness, left flank region, no mental bleed or bladder trauma or hematuria. So, sir, I want to know the hemoglobin CBC for the patient, sir.
Okay.
hemoglobin was
And yeah, but tell me.
And RFT, sir.
serum creatinine was 0.9, sodium and potassium was within normal range.
The most important thing to know at this time is whether the patient has hematuria or not.
Sir.
So
No,
that is something it is not written here. Has he passed urine and does he have hematuria?
No hematuria. So already written, sir, no hematuria, no blood lump.
नहीं लिखा है क्या? Sorry, I missed it then.
Sir.
Okay, ठीक.
Why sir was thinking of hematuria? If there's hematuria, what comes into your mind?
PCS system injury.
Let us change the question.
Pelvic
Sorry?
initial system injury, sir. Like injury extending into the PCS.
It's because of either from the bladder injury, or maybe it's because of the urethral injury, or because of the renal injury that extending to the PCS, sir. It can be
Very good. Very good. So you thought from up to down. That is what we wanted. It could either be urethral injury, bladder injury, ureteric injury, pelvic ileal system injury, or parenchyma with PCS.
Fine.
So,
So next what?
sir, it look like the perinephric collection is because of the renal injury. So, and the patient is stable enough and his RFT is normal. So, I want to do a CCT to grade the injury, sir.
Okay, Brijesh.
बोलो जी क्या लग रहा है अभी?
So, after examining the there is a heterogeneous collection at left kidney at left perinephric area with the extending to the collection is the contrast extravagation. Probably there is contrast extravagation also seen in the one of films. So, and it's a shattered kidney. One. So it's look like.
Amit, do you want to comment?
So what I would have done is I would have read the CT a little systematically.
So on reading the axial images of this CT abdomen with pelvis, the right kidney looks normal, left kidney upper pole is not enhancing, and the mid and lower pole are enhancing, with a collection of a collection over the upper pole of the kidney. On
Mainly, see, you said about enhancement. At the same time, you can see the arterial phase.
yes, sir.
And you can see that there are three small branches of the renal artery which are going to mid and lower pole. But that upper polar branch, we cannot, cannot see it nicely. So with the enhancement, that artery is also not delineated.
Yes,
Plus,
sir.
the collection is involving mainly the upper pole, coming
Upper
up
pole.
to the mid pole. Then, would you
And,
want to also see anything
I would
else?
I would like to see the delayed images if there are.
Delayed and urography, na? You
Yeah.
should have asked for it.
Yes.
Because when a contrast CT is done, you would also want to know urography, na? We were
Yes, sir.
discussing about hematuria. So do you want to see the intactness of the PCS? What is happening to the upper pole, upper
Yes.
calyx? We don't know.
Can I get the delayed images, please?
Abhishek is also said for solid organs. So all the solid organs should be commented about.
And no for the free fruit checker.
So you see, the things you would say
Brijesh,
is that you would start by saying that right kidney looks normal except for a small lower calyx stone.
Yes, I also saw that.
Left kidney, the lower pole and upper pole opacify after contrast injection. I think the last image of the first row is a delayed image where you can see contrast extravasation in the collection. You can see the ureter and the lower calyxes, and there is contrast extravasation seen there. So this is a shattered upper pole of the kidney with injury to the cortex extending to the pelvic ileal system there is no vascular injury. Now, when you are reading this, it is a good idea to say what grade of, the injury it is, as per the ASA grade.
Also, no
so
solid organ injury, no gas under diaphragm.
Absolutely.
fine. So Amit, what is the grade and what are the different grades?
So there are grades, 5 grades in the AST. Like the grade 1, it is the contusion or the capsular hematoma not expanding. The grade 2 is less than 1 centimeter of the laceration in the renal parenchyma, non-expanding hematoma. Grade 3 is greater than 1 centimeter of the renal parenchyma laceration. Grade 4 is the injury extending in the pelvic system or injury in the segmental vessels. Grade 5 is the grade 5, it is the shattered kidney or the injury to the main hilar vessels. And
So what grade is this?
it's probably grade 4, it is, or if it is involving the VCS system. And upper pole artery, I'm not sure about it. Like
Okay, now is the report available, Brijesh? Because they would have seen other details.
So this should be in our findings. We should report it as a grade 4 injury because the
Yes.
lower pole, renal pelvis, and the ureter seems well maintained. Only there is injury to the upper pole with contrast extravasation.
Yes, agree. बताइए जी report.
So wedge-shaped hypoenzymatic hypotenuse defect is also seen in inferior surface of the spleen, consistent with the splenic lacerating injury, non-applicable perisplenic or subcapsular hematoma. Prompt excretion of contrast medium in right kidney and right parenchyma is uniform. No obvious focal lesions on the right side. A small calculus of 10 mm lower pole. Left kidney is enlarged in the size, shows wedge-shaped hypoenzymatic hypotenuse focal areas representing lacerations in the anterolateral cortex of the upper and mid-polar region. Here, these are seen extending medially and involving the collecting systems. There is an associated large mixed density subcapsular hematoma measuring around 2 centimeter in maximum thickness. It causing displacement of the pancreas, spleen superiorly and bowels anteriorly. Mild adjustment, perinephric fluid and fat standing, as well as density hematoma is seen extending along the gyratosphagia fascia as well as along the lateral corneal fascia. So on exterior face, pelvic system on left side, well opposition shows rupture of upper pole with resultant leakage of calyceal contrast in the perinephric space. Rest visual at left kidney shows prompt excretion.
It would have been nice to see the excretory phase actually. Bolo ji, now what do you think, Rathod?
So Hamid, I am giving you 5 options. Okay, Rathod, both of you, I am giving you 5 options. Number 1, don't do anything. Number 2, only put a double J stent. Number 3, don't put a double J stent, only put a perinephric drain. Number 4, you put a double J stent also and open up and remove the clot or whatever it is and try to suture. And number 5, remove the kidney. So Rathod, what you want to do?
Sir, if the patient is CCD shows a grade 4 injury, but patient is stable. There is no. So I want to observe the patient, and I will do this serial monitoring imaging. If its correction is increasing, if the correction is increasing or patient become unstable, then I will go and I will go I will open up. And I will do the upper lobe nephrectomy, sir. Because
So you're very good. You're observing the patient. So now how will you observe the patient? You said one is imaging for the kidney.
sir, I will do this serial ultrasound if hematoma is increasing or patient become unstable. Then I will offer this as
So
surgery.
which are the organs it was touching?
It is touching spleen and
Pancreas.
pancreas.
You said na pancreas.
Sir.
So you'll keep a watch on the enzymes. You'll keep also tell the ultrasound guy to watch the spleen, and you will also watch for the bowel movements.
I will watch him clinically and laboratory. Clinically, first BP and hemoglobin or enzymes. Get enzyme.
Okay. Now, Mohammed, what will you select out of those 5 options?
Amit, do you agree with him?
Amit,
Namat?
sorry.
Yeah. Amit?
Sir, this patient is at present clinically stable. So I would also like to observe him for some time being with the serial hemoglobin, hematocrit, and counts, with along with clinically if he is developing fever or not. At the same time, with the sonography to look for the collection around the kidney is increasing. Is the urinoma since there is a leakage of the upper calyx on the CT scan.
When
So
you're
the
observing him clinically, then see the abdomen also, no? You said everything else
Yeah,
except for
and yes,
abdomen.
sir. And
Okay, go ahead.
locally abdomen. If the urinoma is increasing, I would consider patient for placing the digestant. Uh, and yes, sir.
Only if your urinoma is increasing. Any other signs?
If the patient has local tenderness, fever, and urinoma,
Pain is increasing, fever is
and counts
coming,
is
counts are
increasing.
going up,
Yes, sir.
patient is toxic.
So I want to ask you, Hamid, your treatment will be the same if there is no urinary leakage, in contrast leakage, and if there is a contrast leakage. Your treatment is going to be the same?
So ideally, in contrast leakage, we should place a digestant. So that but as there is very less of contrast leakage, we can observe the patient for some time being. If that is settling, then we can avoid degescenting. If it is not settling, then
Why you're observing in spite of contrast leakage? Is there something which is there in your mind? When distally there is no obstruction, proximal heals.
Yes, sir. When there is
Okay, so
no
distally
distal
there is no
obstruction.
obstruction. There is no urethral injury, bladder injury, stone, ureter is not damaged.
Yes.
Fine. Gite sir, what they should answer in exam?
Sir, current literature wise, when patient is hemodynamically stable, non-expanding, non-pulsatile, अगर hematoma है उसको expanding hematoma या pulsatile hematoma नहीं है, hemodynamically patient stable है, persistent hematuria in spite of conservative treatment नहीं है, तो 90% केसेस में कंजर्वेटिव ट्रीटमेंट ही है और वो स्टेज 5 तक कंजर्वेटिव ट्रीटमेंट लोग कर रहे हैं आजकल.
करेक्ट.
इसमें 100% कंजर्वेटिव ट्रीटमेंट है. कंजर्वेटिव ट्रीटमेंट मतलब स्ट्रिक्ट बेड रेस्ट, टीपीआर, क्लिनिकल पीरियोडिक क्लिनिकल एग्जामिनेशन, टीपीआर, पल्स, बीपी, रेगुलर मॉनिटरिंग इन टर्म्स ऑफ सीबीसी, यूरिन सीबीसी, सीरम क्रिएटिनिन, वो भी एवरीडे सीरम इलेक्ट्रोलाइट्स. And after 48 hours, repeat contrast CT scan. If medial collection is increased, then it should be considered as a pelvic calyceal injury entering into the pelvis. So in such situation, we have to go and repair it. If someone want to do a conservative treatment, then at that time, digestion can be considered. And in spite of that that upper pole is completely shattered from the mid pole, and there is in between heterogeneous collection, that collection may got infected in delayed time. Sometimes the such patient needs a perinephric drainage also. So this is how we will go. And after discharge, again there is a functional study is at the end of 3 months. That is what we usually follow. If anything new, Pankaj sir or any other seniors can add on it.
So I would say that whatever you all answered from Gite sir said, non-expandable, non-pulsatile hematoma. So those 2 words should come in exam. Second, 48 hours.
And there is no
Absolutely.
hematuria.
And 48 hours repeat CT. These 4 things have to be mentioned.
And how many days complete bed rest?
Because in such situations, if you go inside, 70
you will
to 80%
usually find
time,
nothing.
in
You'll
spite
end
of
up in
having
nephrectomy.
excellent experience also, you will end up into the nephrectomy.
Yes, sir.
So Hamid, how many days complete bed rest? 48 hours, 72 hours, 1 week, 7 days, 10 days, 15 days?
for at least 1 week, for at least 2 weeks, sir.
2 weeks.
Okay. And suppose everything is settled. Now patient is after 1.5 months. Will you like to do anything?
Just just a functional scan, sir, as Gita sir said.
And if you think that hematoma is compressing, pressing the pelvic LSL system, you like to go inside or you'll still wait? And if you're waiting, then how many days or months you will like to wait? So that it doesn't become a page kidney.
Sir, if it is compressing, and patient has any symptoms of that, then I would like to
No
do a
symptom. But when you do CT scan, contrast enhanced, you see that pelvic LSL system is compressed from outside.
So I will put a drain, sir.
You think
Percutaneous
that the drain will be able to drain that blood? Have you tried anytime? Which size you will put?
So normally,
It's a
normally
clotted
for the
blood, huh?
collection of the, yes, sir.
See,
That-
sir has asked after 6 weeks. There is no place for drainage after 6 weeks. By then, the hematoma would be absolutely solid. Okay, so
Okay.
unless you see liquefied collection
Exactly.
on sonography, there is no place for putting in a drain. Okay, also, I don't have an answer, but I think 2 weeks of bed rest is a bit excessive. Even I will need to check exactly how much bed rest, but logically, I would feel that if the patient is hemodynamically stable, doesn't have hematuria, then probably 3 to 4 days is all I would keep him on bed rest. And then I would instruct him to avoid exertion and straining. So in this patient, uh, in hospital monitoring, hydration, analgesic SOS, cover with antibiotics, regular monitoring. If increasing urinary, then stent or drain. If say expanding hematoma, only then angiography and angioembolization. The role of open surgery would be very, very low, because if you try to go in, more often than not, you will end up doing a nephrectomy.
Correct. So when you decide to go inside, go with an idea that you might, normally you're going to do nephrectomy and take the consent for the same. And
Yes, sir.
before that, just find out opposite kidney is working well or not.
Yes, sir.
And as Dr. Maheshwari said very rightly, I think maximum 7 days, 4 to 5 days is more than enough, because any hematoma or anything, if it gets dislodged, it will be in the first 4 to 5 days. So primary bleeding is usually seen in first 48 hours, and secondary bleeding after 7 days. So infection or anything. So I think 4 to 5 days, what he said logically is perfect. But still, few people find out how many days complete bed rest.
Yes, sir.
And after
Sir,
6
the
weeks,
the question you asked.
weeks, you don't have to put a drain. If you want to drain it, open up. And that is the time once you remove the clot, okay, you will be able to see some damaged tissue, or you want to take a stitch, you will be able to do it.
So, sir, if even if it is liquefying or it liquefies, we have to open up, sir. Like,
No, if it liquefies, it's very, because 2 cases I am following up, and in both the cases, I try to do the same thing, put a drain, even a little large size drain, but hardly 10, 15, 20 cc it is draining in 48, 72 hours, and then stop. And
yes.
it has not helped me.
So
Okay.
basically,
So you have to open up and
when you try to open up, the aim is to do a proper capsulotomy, so that
Yeah.
the compression of hematoma under the capsule, so parenchymal compression of the hematoma because of entrapment in the capsule would be taken care of. So a generous capsulotomy, suck out whatever clots possible, put a drain, come out. This can be done open, this can be done laparoscopy. Laparoscopically, it will be a difficult procedure. If you have an experienced laparoscopic surgeon, can be attempted.
Correct. Yeah, so the removal of the clot is okay laparoscopically. But as you said very rightly, you need someone who, because it is not a normal anatomy. And to find out where is a tear and to suture it and to take a suture in such a way that it doesn't cause more tear is really difficult. So, and before that, always put a double J. And after finishing it, put a drain and come out. Okay, fine. Brijesh, next case.
One more thing, long-term follow-up, blood pressure monitoring.
Yes.
Very important.
Yes,
And
very important.
another thing, he can return to work. It is given, but how much bed rest it is not going. I am absolutely agreeing with Pankaj sir. 72 hours to 5 days is at the max it is required, but nowhere it is written how many days bed
Yeah.
rest to be given. Return to activity it is given 12 week. In various articles, it is 12 week is the timing used for return to the activities, like that including sport activities. तो 12 वीक तक का तो कुछ करना नहीं है और बेड रेस्ट 3 to 5 days आंसर यूजुअली एक्सेप्ट हो जाता है, कोई प्रॉब्लम नहीं आएगा.
So you can say that complete bed rest for 3 to 5 days and can resume duties after 12 weeks. Finish. I think that will be an equivocal answer. Fine. Okay, Brijesh, next case.
So, 48-year-old male who was a chronic kidney disease patient had underwent a kidney transplant. On discharge, patient was comfortable. On post-op day 8th and 9th, the Foley's catheter and drains were removed. So, patient returned to post-op day 20 with scrotal and penile swelling. Investigation showed hemoglobin post day 20, 9.8, count slightly raised and create 2.2. Previously, it was create was 0.9, and he was fit for the discharge. So, image of the
Yes. Anyone else wants to answer apart from Hamid and Rathod? Is there?
I think we should
You
ask
can
Pushkar to
unmute
answer.
yourself. Pardon?
Pushkar.
We should ask Pushkar to answer. He was having a background noise.
Yeah. Yes, Pushkar. Would you like to answer?
But I am much thankful to the Pushkar because I am not feeling well. Having repeated dry cough, he used my old opinion to give to give answer to questions today also.
And he removed his name now. It is written Vivo.
No problem. Yes, Pushkar, you want to answer? If you want to answer, please. Okay? This is the right time. Okay, no problem. So, Mohammed?
Yes, sir.
Hamid? Yeah, what next?
So, this patient is presenting with the right-sided fullness and scrotal swelling, and his creatinine also rising on the same side of the and of the transplant done. I would like to do a sonography of the patient to look for any developing hydronephrosis, as there is a collection and it may compresses the ureter. So I would want to see the sonography of this patient.
So I want to know how's the operative site is there? Any others? Is there any swelling on the suprapubic region, or is there not on? What is the urine output, sir? Now it's a urine output.
So what are you all suspecting, both of you? What could be the different scenarios? What do you think this collection is?
It's either lymph or urine, sir. There are two possibilities are there. So if its urine output is decreasing say after that last 4 or 5 days. So it's very high likely it's because of urine is there. It's, so
urine output would decrease in both of the conditions. If it is compressing the
Yeah.
ureter in the lymphocyte, it will decrease, or if there is a urine leak, then in both of the cases, urine output will decrease. But if the patient is not having any bowel symptoms or anything, it's probably a lymphocyte, not a urine leak. So otherwise, it will irritate the bowel, and he may
Have you
present a
asked whether the patient was stented or not?
No, sir.
Isn't that very important?
Yes, sir. Yes.
Then, so
And
this patient was not stented.
And I also want to know the intraoperative finding also. Sir. It was
No,
during
intraoperative, the surgery was done very well. Okay. And even the vascular anastomosis was over almost, you can say, in 17 to 18 minutes.
So we in this entire session we saw two cases. Every time you must ask how was the surgery, were there any events? That is a must in such cases.
During the making of the recipient bed, was the peritoneum was opened or not? So
No, peritoneum was not open. The bed preparation was done perfectly. The anastomosis, internal iliac with the renal artery anastomosis was done, and external iliac vein with the renal vein. End-to-side anastomosis was done. After anastomosis, there was hardly any bleeding. The ureter was bleeding very well. Okay, and anastomosis was quite wide, reasonably wide, and it was
stent was placed.
The stent was not.
Stent was not placed.
No, because everything was very good. Anastomosis, ureteric anastomosis, ureter vesical anastomosis was very good. So it was not kept.
And I also want to know, is there any graft tenderness is there or not? So because he's a ABO incompatible patient, so very his swelling is not because of it, but maybe have some part of rejection also.
So you are suspecting, one is there can be some rejection. Number two, that can be a lymphocyte. Number three, a urinary leak. That is what your differential diagnosis is, right?
Sir.
So if there is a urinary leak, from where it is?
Probably its most common site is anastomosis site, sir.
Is there any other place?
It can be from the pelvis also, pelvis also, sir. But
why?
It's a pelvis. Maybe the unidentified injury at the of the pelvis, but okay.
No. Anyway, but
Sir.
it is usually from the anastomosis.
Sir.
Okay.
Sir.
Fine. And what are the causes?
Its causes is
most important.
Yeah,
cause is ischemia. Most important cause post-surgery is ischemia, or there might be infection. There might be the anastomosis under tension, and there can be, but most common cause is ischemia and yes, sir, or the anastomosis under
Infection
tension.
and the tension. And post-operatively, if the catheter is removed very early,
yes,
some people have got a habit of removing. I know one nephrologist, 4th or 5th day he is removing. And so the bladder gets filled up, and then sometime it can cause. Fine. Okay.
But sir, if the stent is there, like shouldn't it be?
No, stent is not there. No?
Sir, what is the ideal duration to remove the Foley's after the transplant, sir? We follow here as an institute when the urine output is less than 3 liters, then we generally remove the Foley's. I don't know. When should we remove the Foley's, sir?
See, in our institute, we removed on the 7th day.
Okay, sir.
Because by that time the healing takes place, and then we wait for the drain. If the drain is not draining more than 50 cc, then we remove.
So it could be institution to institution protocol. So
Yeah, yeah.
usually 6 to 7 days good epithelialization occurs. And once you remove Foley's and there is no leakage and no drain, then you can remove the drain.
Yes, sir.
Okay, so now what you? So show the ultrasonography, Brijesh.
So USG suggested that there was extended scrotal edema with bilateral testicular supply was no any hydrocele or any intra-testicular collection.
No,
And
testicular ke intrascrotal collection.
so there was no TVH,
Yes.
no tunica vaginal hydrocele.
Right. So there
So
was
it was
no
basically
collection, it is
the
only edema.
edema in the scrotal wall and
Okay, sir.
extending up to the suprapubic and even on the little on the right hand.
Okay, sir.
Is there any collection around the graft, sir? Or in any intra-abdominal collection?
Not much.
No.
Okay, sir. And
So what
how
you
is
will do?
it's a hydronephrosis there in or not, sir?
Yeah, there was a mild hydronephrosis.
Okay, sir. So in that case, I want to I will put the Foley's catheter, sir, in the
Okay.
in this patient, and
Okay.
Observe how is this how he is responding, sir. If the swelling is reducing, urine output is increasing, and then it's probably because of the urine leak. If it
So I'm asking, I'm giving you the scenario. Number one, you will do the CT scan. Number one. Number two, and after CT scan, you will decide what you want to do. Number two, you will put a Foley's catheter. Number three, you will do Foley's catheterization. At the same time, you will do, because there is a mild hydronephrosis and there is a creatinine which is increasing, you will do percutaneous ultrasonography guided PCN. And number four, you will do even the digestion.
What I also expected from you that the general measures you will start, no? You said you'll put a Foley's catheter, give scrotal support. Maybe you can give him a diuretic, to reduce the edema. All these things you can do because ultrasound said it was only edema. There's no collection. And then go ahead with the CT because you want to study around the graft, around the ureter, any collection or anything. So general measures you will take and then go ahead with the CT scan.
CT scan, so we can wait because creatinine is 2.2. We should wait for some time, or we should do immediately, sir.
Yeah. No, I'm asking you.
Sir,
Yeah, I have given you all the option. What you will do?
Sir, I will do. I will put a Foley's catheter, and I will do the general measure in form of the elevation of the scrotum, and I observe serially creatine levels, sir.
His count was high, so you'll give antibiotic.
Yeah, antibiotic also, sir. If it's in spite of putting Foley's, if it's count creatinine level is increasing or the swelling is then I will do the CCT, sir, to know if there is. You
will do CCT or you will put up nephrostomy.
If then I will do the sorry, sir. I will do the nephrostomy in that case, sir. And then I will observe how the
is ultrasound suggestive of distended bladder, significant postward residue, mild hydronephrosis, moderate or severe hydronephrosis, perinephric collection? Anything is there?
Nothing.
No, sir.
Only edema was there.
But if it is only a subcutaneous scrotal wall edema, so considering increased TLC, antibiotic can be concerned, catheterization can be concerned because the edema may be causing problem in passing the urine.
Plus you must also ask
यूरेथ्रा तो अच्छा है लेकिन वो कभी कभी बॉडी पे यूरिन हो जाता है बल्कि डर के मारे करते नहीं है लेकिन ये जो क्रिएटिनिन रेज हो गया है उसका और ये स्क्रोटल वॉल इडिमा का कुछ रिलेशन रहने का चांस कुछ दिख रहा नहीं है इसमें अभी तक तो। अच्छा,
And
गुड
also you have
सोनोलॉजिस्ट
to
का
check
अगर सोनोग्राफी
immunosuppression.
है, सोनोग्राफी अगर गुड सोनोलॉजिस्ट का है, तो ये हमको ऐसा कोई क्लू नहीं दे रहा है कि जिसमें हम सिटी स्कैन के लिए रन करें।
और हाइड्रोनेफ्रोसिस भी नहीं है, नो हाइड्रोयूरेटर.
Yeah, mild hydronephrosis is there.
Okay.
So I agree with Gite ji, and I also agree with whatever Rathore is saying. That is absolutely right.
Also, immunosuppression needs to be checked with
Yeah.
nephrologist.
So that all the markers and everything you have to see whether it is not toxicity. Na? That is number one. Why creatinine? And there is no rejection. So these are the two things medically you rule out, and surgically, yes, you put the Foley's catheter and give this support antibiotics, anti-inflammatory, non-NSAID, and then see. And if it is not improving and the hydronephrosis is increasing and the output is decreasing, then intervene. So, Brijesh, क्या किया था?
So patient was managed conservatively. Foley's catheterizer and scrotal support was given.
Yeah, and the antibiotic, and then he improved.
He improved.
So probably there was a small leak from the uretrovesical anastomosis. Okay.
Sir.
And I think last time or last this series or earlier, we had put a similar case where there was actually urine. It was coming out from the scrotal wall. We had collected it, that fluid. It was dribbling. It was dribbling. Same scenario, but severe edema. First, we thought it is a Fournier's gangrene, but no. And then the urine was actually leaking. So in that case, you have to go totally out of the thing. You have to do maximum what you can.
Did you manage a
Because
stent, sir, in that or PCN?
no, it
इसमें
was
स्टेंट नहीं था क्या सर?
नहीं, इसमें स्टैंड नहीं था. तो दूसरे केस में भी स्टैंड नहीं था.
ओके सर.
Right.
This patient, after putting the police catheter, he improved and he started passing urine, edema subsided, and then later on
This patient you
creatinine
must
also
also
improved.
check for prostatic obstruction. So alpha blockers with Foley's catheter is a must.
Yes, sir.
In this patient, we did MRI. MRI showed leak from the urine.
Acha, acha.
Bridges, you have got MRI?
No, sir, unfortunately, I
Previous
don't.
ward case that we have presented. What's the name?
We had presented that earlier case, no, with the
MRI is there in previous.
yeah. In that there was a leak, na MRI.
Mid-ureter leak was there.
Yeah, mid-ureter. Yes. So as Rathod said, unknowingly it was damaged or even the vascularity had gone away during the dissection. Fine. Okay.
So many interesting
Next.
cases and so much thinking.
Yes.
Good class.
Still want to go ahead now or want to, because we have got 3-4 more cases, or we can continue next time? What is the suggestion?
11 बज गए सर अभी.
So next time करते हैं ना? We have got 4 cases.
Yes.
Good cases. We have got good cases. Better to keep it next time.
इसमें मैं ये सरप्राइज हूँ कि दैट लीक भी अगर रहा तो ओनली वो स्क्रोटल वॉल में कहाँ से पहुंचा. Because in spite of not having any perineal butterfly, कुछ ऐसा hemorrhagic contusion के जैसा पिक्चर नहीं है, डिस्कलरेशन नहीं है, वहाँ कुछ हेमाटोमा नहीं है, यहाँ वहाँ कुछ कलेक्शन नहीं है, ओनली स्क्रोटल वॉल में कैसे गया होगा ये मैं जब से सोच रहा हूँ.
नहीं, I'll tell you what happens.
Mobilization of bladder and that.
No, both the things. So what happens that when we are doing the transplant, who is preparing the bed? That is important. So now sometimes the newcomer is there, he is little more aggressive and he tries to dissect the external iliac vein up to the inguinal ligament also. And then at the same time, you are doing lots of dissection for the bladder also. combine these two, there is a space which is going up to the scrotum. And then when the leakage takes place, probably this is one of the easy route to go down.
I think dissection must be going too much down till inguinal. That is
Down.
must be
Yeah,
the
yeah.
problem. Yeah.
That must be.
पंकज सर, आपको क्या लगता है? Anyway, how it will reach inside the wall only?
No, it is, sir, even with the mechanism you have said, it is difficult to explain because even then it should be more in the sac rather than in the wall.
Exactly.
So, but okay, if it has responded to folic catheter and antibiotics, then probably what you are saying may be true.
And
Maybe some
I'm
compression of
just
lymphatics.
asking for discussion because theoretically कैसा prove हो सकता है
नहीं,
वो?
Gita sir, second case was there na. If I mean, we will show it. We already discussed last time the second case where it perforated the means it, the scrotal wall and the fluid was dribbling. And when we collected that, it turned out to be urine.
Here maybe some lymphatics were also getting obstructed.
Maybe.
Lymphatic.
But this patient improved after putting the catheter.
Anyway, patient improve हो गया, वो important है. छोड़ो.
Important. Correct. But now they know how to answer in exam when something like this comes. Because see, what is happening is that in a ward round, they are not going to keep only the routine cases which everyone can answer. So when they get some cases like this, they are going to put it.
Yes, sir.
And Gita sir, welcome. I hope your health is very good now. And
ठीक
you
है सर,
cut
अभी
down
थोड़ा
your
सा
traveling.
ड्राई कप कंटिन्यूस चल रहा है, लेकिन I can join. आज थोड़ा
Yes.
एक्टिवली बात कर सकता था.
आज आपका recorded और live दोनों
दोनों एक साथ हो गए.
Good.
महेश
And
जी,
we have not said, I think congratulations to almost all the students. I think they have passed.
Yes, sir.
Correct?
Yes, sir.
Anyone can tell me what is the result? Rathore? Ame? Any one of you can tell me? I think it must be almost 100%.
I think, sir, I didn't.
And I hope that those who are attending our clinic, their result is 100%.
I hope so, sir. I think so, sir. No one is. I think no one is failed in theory, sir, with mild knowledge.
Okay. So to whomever you have asked, they have passed in theory, correct?
Sir.
Good.
Very good. Proud of you guys. अभी पढ़ो अच्छे से practical के लिए.
Fine.
Thank you,
Okay.
sir.
Okay.
Thank you, sir.
Good night.
Good night, sir.
Thank you, Gite sir,
Maheshwari ji,
Pankaj
thank
sir,
you very
Gaurang
much.
sir.
Yes, Ganesh
sir.
bhai, thank you.
अरे सर, थैंक यू की क्या बात है? आपके
नहीं,
साथ हम
because-
सीखते रहते हैं सर.
Yeah, but so many things. So that is why I am putting forward whatever we have done. So at least we come to know what should be the right thing and how to answer in the exam. Because in the institute, it is up to the boss who is doing the procedure. And that doesn't mean that you have to blindly follow it. That is the most important thing. Right.
बिल्कुल सर.
Good night,
Okay.
sir. Happy
Good
Holi
night,
to all.
good
Good
night,
night. Good night.
Good night.
Happy Holi to all.
Thank you, sir. Happy holiday also.
Thank you. Yes, happy Holi to all of you.
Sir.